Assalamu alaikum and welcome everyone. Inshallah, today we will start our case number 6, V pattern esotropia after Lasik. Dr. Aima, can you please start reading the case?
Yes, sir. Assalamu alaikum, everyone. So the case we'll be going over today is V esotropia after LASIK. A 49-year-old woman presents with double vision. She developed exotropia in childhood. At age 5, she had surgery in one or both eyes. She had good alignment after surgery, but after a few years, the eyes started crossing in, for which she required prism glasses. At age 16, she switched to contact lenses for myopia and abandoned prisms. At age 41, she had LASIK surgery for myopia with a good refractive outcome. Soon after LASIK surgery, she became aware of diplopia and was prescribed prism glasses by an optometrist, mainly for near. For 2 months, she has had poor vision at distance and near, with trouble using her eyes together. She feels her eyes pulling in. Her optometrist requested a surgical consult before offering vision therapy exercises.
Okay, Dr. Aima. Dr. Muhammad, do you want to add any comment here about this case?
It's very rare cases like this. Something hidden inside this case. Maybe there is a residual squint or consecutive squint after the exotropia surgery, which operated at childhood. So mostly she had a hidden squint or like phoria or like something which appeared after refractive surgery.
Yes,
Let's read the examination.
okay. Just I want to say here, this patient, she came with exotropia since she was childhood. And she did
Yes.
exotropia surgery. And after the exotropia surgery, she developed consecutive esotropia. And this consecutive esotropia, they didn't do any surgery for it. Just they give her a prisms, try
Mm.
to treat the consecutive esotropia with prism glasses. And at
Yes.
16 years, they stop the prism glasses and they start giving her contact lenses. And at 41, she did a LASIK surgery. And after the LASIK surgery, she developed again a V pattern esotropia. Let us go to the paragraph and discuss this case more. This is just a conclusion for the case. Yes, Dr. Aima?
Examination. Current prescription. Distance glasses for the right eye minus 0.75 sapphire and plus 0.75 cylinder at 15 degrees. In the left eye, it's minus 0.75 sapphire and 1 cylinder at 115 degrees with no prism. Reading glasses in the right eye are plus 1 and plus 0.75 at 10 degrees with 7 prism diopters base out. And in the left eye is plus 0.5 and 1 cylinder at 115 degrees with 7 prism diopters base out. Visual acuity with correction in both the eyes is 20 by 15. The manifest refraction in the right eye is plano plus 0.75 at 15 degrees, and in the left eye is minus 0.5 and plus 0.75 at 15 degrees. External examination shows chin down head posture. Sensory motor evaluation, motility, ductions, and versions full with no oblique overaction appreciated. Deviations, distance corrected esotropia 16 and near corrected esotropia 26 and intermittent right hypertropia of 2 degrees and esotropia 32 degrees in down gaze.
So here, according to the deviation, when they said esotropia 32 in down gaze, that means they talk about V pattern, more esotropia in the down gaze position. So this is V pattern esotropia, and it's more at the near more than the distance. Here, these are the picture. We can see here the esotropia very clearly, especially here in the right eye. Yes, Dr. Muhammad, do you want to make any comment at this picture, please?
I looked to different gazes here. I didn't see any obliques overaction like inferior oblique overaction. And I'm query about the causes of V pattern here after the initial surgery for exotropia. I think the causes for this V pattern here is a consecutive esotropia, and also there is a heterotropia bully. Again, bully heterotropia, which is the causes for pattern here, or maybe iatrogenic by displacement of the lateral rectus muscle, especially toward downward. So
Okay,
the causes here for pattern for V pattern after the exotropia surgery may be due to polyheterotropia or due to iatrogenic down
displacement.
displacement for lateral rectus.
But what do you mean by polyheterotropia?
This is the causes. Okay, when you say the causes of patterns like A pattern and V pattern, there is a lot of causes. One of the causes is polyheterotropia. The causes here is a horizontal muscle, not the vertical muscle or obliques muscle.
Yes.
Okay, this is needs a lot of explanation why. Because the bully here, it's not in the anatomic location, it's like upper or lower location for the normal location,
So
which is the which
you mean the horizontal recti muscle belly,
yes,
it's
yes.
go a little bit downward after the surgery. So this is will make the
This is the iatrogenic cause, but
iatrogenic.
yes, but the causes which originally I said polyheterotropia. This is from birth. The bully of the horizontal muscle medial rectus or lateral rectus, which a little bit up or a little bit down,
So it's like a
which goes in the birth.
congenital. Yeah.
Congenital, yes.
Okay. Thank you, doctor.
Okay.
Yes, Dr. Muhammad. Do you want to add anything else?
No. Okay, let's see.
Okay. Yes, Dr. Aima, please go on.
Stereopsis with prism glasses, 140 arc second, dilated fundus examination, unremarkable, no fundus torsion in either eye. This was double checked and triple checked.
Continue.
Dr. Hunter's assessment plan. The patient most likely had a childhood onset intermittent exotropia that became symptomatic by age 5 to the point where she required strabismus surgery. One of the most worrisome and common potential complications of early surgery for intermittent exotropia is a consecutive esotropia, which may cause permanent loss of binocular vision. Unfortunately, it looks like that is what happened to this patient, but in her case, her ophthalmologist prescribed prism glasses to successfully preserve binocular function. Over the years, she developed fusional amplitudes for a change in alignment that finally allowed her to abandon prisms when, as a teenager, she began to wear contact lenses. She managed to function for years without prisms, probably helped along by the V pattern that allowed her to use a chin down head posture to regain fusions. At age 41, she had Lasik to treat her myopia, and the problem was compounded by the final refraction, which left her mildly hyperopic in at least one eye. Spherical equivalent of the manifest refraction is plus 0.37 on the right and minus 0.12 on the left. This disrupted her already tedious control of binocular vision and made her dependent on prisms for reading, either because of the larger esotropia and down gaze, thanks to the V pattern, or because of the accommodative requirement for near. Why then does she have a V pattern? It does not appear to be due to inferior oblique overaction in this case, because there is no fundus torsion and no over elevation in adduction. One unifying explanation is that she had bilateral lateral rectus recessions for exotropia, but the muscles did not adhere properly to the eye, allowing them to slip posteriorly and also to drift downward. Since upward transposition of the lateral rectus muscle treats a V pattern, downward transposition should create a V pattern. She's scheduled for vision therapy exercises. However, it would be very difficult for a patient to learn how to actively diverge the eyes by 16 prism diopters for any sustained period. Furthermore, with the V pattern, no matter how good she is at exercises, she will continue to have trouble in down gaze. It would be possible to defer surgery by increasing the prism power in the glasses, but bifocals would not be tolerated due to the larger esotropia in down gaze, and the point of having LASIK in the first place was to reduce dependence on glasses. Therefore, I plan to perform bilateral median rectus recessions. For patients with esotropia graded at near, I tend to operate on the near angle with correction. Looking at Appendix 1 for 25 prism diopters, that would be 4 millimeter recessions in both medial rectus muscles. Inferior oblique recessions are not necessary here in the absence of torsion or over elevation in adduction, so I will just transpose the medial rectus muscles down by half tendon width for the V pattern. However, we do not know exactly what surgery was performed in childhood, so we have to be prepared to change our plan and, for example, perform a recess resect procedure on one eye.
Okay, Dr. Ayman. Yes, Dr. Muhammad, what did you think about the plan? And
Again, routinely, after the exotropia surgery at like 5 years, which is the preferred age for us, because below the 5 years, we afraid from the consecutive esotropia, which is amblyogenic for the patient. So the best age for the intermittent exotropia intervention, it should be like at 5 years of age and later on. Again, the preferred angle after the surgery, it's like the orthotropia, or some like esophoria or esotropia within 10 prism diopter. But when we have a patient with consecutive esotropia within 8 to 10 prism diopter, we don't afford him like a prism for glasses, with the glasses, because we should encourage the divergence amplitude for this patient to overcome this consecutive esotropia. This is the best solution, I think, worldwide. So here the problem is the patient completely depend on the prism when she had a consecutive esotropia. And after that, I don't know why she had
loss.
a good fusional. No, she developed fusional amplitude. But after that, she abandoned prism when she was a teenager. So this is the main concern here. Another thing also, the causes of V pattern, as I said before. Okay. Another thing again. Yes. About the treatment of the pattern without oblique overaction, it depends on the rule of male, which is the shift of the medial rectus or lateral rectus, medial rectus toward the apex, and toward the apex of the alphabetical pattern, and the lateral rectus towards the empty space of alphabetical patterns. Half tendon should be correct about 10 to 15 prism diopter, and full tendon shift will correct like 25 to 30 prism diopter.
Okay, let me just make a conclusion. First of all, you talk about that the most proper age to do the intermittent exotropia at age 5 years or more than that. This is the
Yes.
first point, as I get it from you.
We have an exception. What is
Yeah.
the exception for the operation or surgery before 5 years of age in the exotropia? when the intermittent exotropia convert from intermittent to constant exotropia, when the control is like a poor control and also manifest almost all the time. This is the exception for the surgery because just think when you have a patient with 3 years age of 3 years old of age with constant exotropia, you cannot leave them with the constant exotropia because here a constant exotropia will be amblyogenic for them. But here the target of the angle should be like an ortho or residual exo, not an esotropia within 8 to 10 prism of diopter. Because if you have an consecutive ESO here at like 3 years old of age, almost this patient will have an amblyopia.
Okay,
So
so
the angle, the target of the angle here, it should like a residual exo or the orthotropia.
so here you said here at 5 years the target of your angle it should be ortho or esophoria until 10 prism diopter, consecutive
Yes,
10 prism diopter. But when
yes.
you said it's a 3 years and he has large angle exotropia, your target is to still residual exophoria or ortho. This is what you mean?
We will be happy also here if you convert this patient from constant exotropia to intermittent exotropia.
Okay.
Very happy because the intermittency of the squint, it means like this patient has a good vision and has a good stereopsis, which is the main of the surgery here.
Yes, yes. Okay, I get it now. Thank you, Dr. Muhammad. Just again to conclude the male rule, what is the male rule? So we will have male rule or do the V pattern or A pattern of esotropia. So we will go for male rule. What is male? Male, the medial rectus, it will go to the apex of the muscle. So here we have the V pattern. So the medial rectus, it will go to the apex. The apex is downward here. So you will remove it downward about half tendon. Half tendon, it will give you 15 prism diopter corrected, and full tendon, it will correct about 25 prism diopter. And the lateral rectus, medial rectus to the apex, and lateral rectus to the empty space. So the lateral rectus, it will go upward. Okay, and this is we will do it in each case of A pattern or V pattern. A pattern, it will be the opposite. I hope it's clear. Also, Kansky and American Academy explain my rule in a very good way. Okay, let us continue. Dr. Aima, the surgery.
Surgery. Under anesthesia, both eyes were esotropic, and it appeared that both lateral rectus muscles had been operated on previously. So I proceeded with a planned bilateral medial rectus recessions with downward displacement. Although small incision fornix surgery was used, there was a small conjunctival tear on the right that required closure with a single buried 8-0 polyglutin 910 suture. Procedure summary. Recess right medial rectus 4 mm adjustable with downward displacement half tendon width. Recess left medial rectus 4 mm adjustable with downward displacement half tendon width.
Okay, before we go to the post-operative assessment, so if we go to the angle of near, he said I will work at the angle of near and it's a 25 prism diopter. If just I want to follow the 15 rule, as I mentioned in the first lecture, 25 plus 15, it will equal to 40. Then you should divide it by 10, so it will equal to 4 millimeter. So you will do 4 millimeter medial rectus recession in each case. He is target at 25, and according to 15 rule, it will be the same recession in each muscle. Okay, do you want to add anything, Dr. Muhammad, before we
Yes,
go?
yes.
Yes.
I have a question for you, Dr. Abdurrahman. What is the best management for consecutive esotropia? Surgical management. If you have a case like this, you will operate on the lateral rectus by advancement of the lateral rectus, or you will operate on the medial rectus here.
How much the consecutive? You mean more than 15 prism diopter?
Like this, 25.
Actually, we go for advancement, but mostly, as I saw, most of the cases that we did advancement for it, it's the opposite. He has bilateral medial rectus recession for esotropia, then he have consecutive exo, then we do again just the surgery by advancement, the medial
I think
rectus.
I think I think we have a rules here.
Yeah,
When you are operating the patient with long-standing consecutive esotropia, I think it should operate on the medial rectus here. But if you had like a slipped lateral rectus fibers, you should operate on the lateral rectus. If you had a patient with recently operated for the intermittent exotropia and has after that consecutive esotropia, you should operate on the lateral rectus by advancement of the lateral rectus. So the rules here, it depends about if you have a slipped fibers. If you have a slipped fibers, you should operate on this muscle. But if you had a long-standing consecutive esotropia, you should operate on the antagonist muscle, which is here a medial rectus.
okay. And when you do advancement of the lateral rectus,
Recently consecutive,
yes,
or if you had slipped fibers.
okay. Thank you so much, Dr. Muhammad. Yes, Dr. Aima, please go on.
And
Post
again, I had also some points. If you have an angle is more at near is more than at far, you should operate on the medial rectus, and the opposite the same. If you have an angle is at far is more than a near, you should operate on the lateral rectus.
But not everyone go for this rule. Like if the esotropia for far, you will go for lateral rectus. Absolutely.
Mm, this is the preferred approach, really.
Okay. Okay.
And
But
also if you have like a patient with very large angle at near, like a high ACA ratio, esotropia, it should operate on the medial rectus with Faden procedure.
yes, yes. Okay, I want to ask you here, like he work at the angle of near. Why he
Mm.
didn't go for like we have, standard rule, we have the augmented rule. So
This is
why?
this is this is not this is not partial accommodative esotropia.
Okay. So this is the cause. This is consecutive. So we didn't follow the other rule of partial accommodative.
Yes.
Okay, okay. Let us continue, Dr. Aima. Do you want to add anything else, Dr. Muhammad?
No.
Okay. Yes, Aima, please.
Postoperative assessment. 1.5 hours after surgery, she had the following measurements: distance corrected esotropia 3 degrees and distance uncorrected esotropia 4 degrees, near corrected exotropia flick, and near uncorrected esotropia 2. No V pattern was evident. Note that when performing these measurements in the recovery room, I took care to provide near correction that had no prism during the suture adjustment. I keep over the counter reading glasses in my suture adjustment bag. I'm aware of a patient who had suture adjustment performed with prism glasses and who ended up remaining dependent on prism glasses. While I do not like to undercorrect esotropia, I definitely do not like to overcorrect. And in this case, she was on precipice of overcorrection at near, so I decided not to adjust. Follow up. About 2 weeks after surgery, the patient returned prior to her scheduled post-operative visit, describing severe irritation on the right. On slit lamp examination, she had an exposed 8-0 vicral conjunctival suture at the limbus in the right eye. This was removed under topical anesthesia at the slit lamp with immediate relief. She then returned for 2-month post-operative visit, noting that the eyes were straight with no diplopia but describing some redness of the eyes. Examination: current prescription, distance none, near 1.25 over the counter reading glasses. Visual acuity without correction in the right and left eye 20/15. Sensorimotor evaluation, mild limitation of adduction on the left, deviations. Distance uncorrected esotropia 4, near corrected intermittent esotropia 4 to 6 degrees, right hypertropia 2 to 4 degrees. Excellent control. Stereopsis 140 arc second. Slit lamp examination. Conjunctival hyperemia as anticipated 2 months after strabismus surgery.
Okay, before we go to the review lesson learned, here this is the pictures after the surgery, and this is clear here. You see the conjunctival hyperemia still after 2 months after the surgery. Dr. Muhammad, do you want to make any comment here?
No,
What did you think?
it's very good the procedure here.
Yeah, and look here in the primary position, it's look like straight, like in the primary. Yes, you didn't see the esotropia like before. Okay, let us continue, Dr. Aima. What is the review?
Review lessons learned. The patient chose to have LASIK to correct myopia just as she was entering her presbyopic years. It is important for patients in their late 30s and 40s, whether or not they have a history of strabismus, to be well informed of the trade offs or having refractive surgery at that age. Specifically, while the goal is to become free of glasses, in the early presbyopic years, the outcome may just likely be trading a dependence on distance glasses for a dependence on reading glasses. In our patient, there was the added complexity of the history of diplopia and prism dependence caused by strabismus. Strabismus and diplopia are recognized potential complications of refractive surgery. Kowal and colleagues describe screening tests to stratify refractive surgery patients into different risk groups to identify those requiring additional evaluation before undergoing the procedure. They recommend that all patients scheduled for refractive surgery undergo the following tests. Ask about history of prior strabismus, eye exercises, or prisms. Check glasses for prisms or effective prism caused by displacement of optical centers. Cover, uncover, and alternate cover test. Check for absolute and manifest hyperopia. Fusional amplitudes in moderate to high risk patients. They describe the high risk group as patients with one of the following: diplopia while on trial of monovision, accommodative esotropia requiring substantially more plus correction than the absolute hyperopia to control the deviation, anisometropia of greater than 4 diopters even if good fusion is present, manifest strabismus. In this case, the patient may have slipped under the refractive surgeon's radar since she was not experiencing diplopia and not wearing prisms, at least not at the time of surgery. We do not know if cover testing was performed. It is essential for an adult strabismus surgeon to perform a refraction on every new patient, even if corrected visual acuity is 20/20. Some patients may retain good accommodation into their 50s, and I have treated diplopia and deferred or avoided strabismus surgery in such patients simply by reducing an excessive amount of minus power. In this case, I did find the patient was wearing slightly more minus power than she needed, but I did not think that reducing the glasses just by 0.5 diopters would help, and she was already wearing reading glasses with prism. At the time of suture adjustment, it is important to check the glasses for prism before performing the measurements. The wrong glasses may end up in your hands for any number of reasons. For example, the patient might be in a hurry and grab old prism glasses instead of newly made prism-free glasses on the way to the hospital. Prism can be identified at the bedside without special equipment by performing straight edge test, holding the glasses in front of the straight surface and looking for deviation of the edge through the optical centers of the lens.
The surgery seems to have helped. The small medial rectus recessions and transpositions appear to have taken care of V esotropia. I am not convinced the -1 adduction limitation on the left noted at the postoperative visit is real, since it is not borne out in side gaze measurements, and even the photos do not really support it. I see no reason to anticipate future problems with this patient, but she should continue to wear her reading glasses to avoid over-accommodation and recurrence of her esotropia.
Okay, thank you so much, Dr. Aima. Okay, Dr. Muhammad, how you can conclude the last paragraph review lessons learned about this case?
Really, we have in general, we have a lot of problems with refractive surgeons because most of the refractive surgeon missed the part of the squint and the part of the foria and the part of the hidden squint like fourth nerve palsy and sometimes restriction in the extraocular modality and sometimes restriction or poor stereopsis. Because of that, we had a lot of the surprises here after the refractive surgery. I think it should. I will arrange for a lecture with a squint and surprises after the refractive surgery. I have like 5 to 6 cases with surprises after the refractive surgery because of a poor examination before the surgery, which was of them this case. I think if the surgeon here detect that the patient had a squint surgery at 5 years of age and do cover and cover and detect the esotropia, which was at the primary position and increases on the down gaze and decreases on the up gaze with shin down position. I think this is the better way here. It should transfer this patient to squint surgeon before doing any refractive surgery for this patient.
Okay. What's about this is a straight edge test to assess for prism in spectacle lenses? They said here in picture A
It's
there is no
simple. This
prism.
is simple
Yeah.
because the prism inside the glasses it should displace the image. The glasses, the routine glasses, it shouldn't differ the placement of the object, but the prism here it should displace the image toward the apex of the prism.
Yes, here they said that in picture A there is no prism as you see here, and there is the table edge forms a single continuous line through and between both lenses. You will see it's continuous. Look at the table here, and there is no any discontinuation. But in the other picture there is a prism, and if you look at this vertical prism, you can see the table edge to appear discontinuous like here it's discontinuous table, not like in the previous picture. This is how to differentiate there is a prism or not. It's simple test. Okay,
You
let
know
us,
the type
yes,
of prism here inside the image? What is the prism here?
here they mention it's vertical, but for me,
It's a
uh,
Fresnel prism.
yes, Fresnel prism,
Yes.
yes. Okay, Fresnel prism vertical type. Do you want to add anything else?
Fresnel, you have a Fresnel prism with anything you want. Prism, base up, base down, base in, base out.
Yes, yes.
Anything. I have some comments on the prism uses of prism in the squint. If you want to use the prism like exercise, you should the base alongside the direction of the squint. Like divergence or sorry, convergence insufficiency. Convergence insufficiency patients. The convergence insufficiency patient, this is the type of the exotropia, which is very large at near than at far. So here, the direction of the prism base, it should be like out, base out prism.
Yes.
So when you use a prism when with the exercise purpose, the location and the direction of the
Will be the
prism
opposite.
in the exercise, it should be in the same direction of the squint.
Yes, yes. The base it will be here. The base it will be out, and the apex it will be
Yes,
in. Yeah.
yes.
Yes,
This is
but
this is the purpose here for exercise.
yes,
But if you want to relieve the symptoms of the patient, the base it should be opposite to direction of the squint.
yes, yes. It will be base in, so you will correct the convergence insufficiency. But for exercise, it should be the opposite. It was one of the MCQ question before I face it. Uh, okay, Dr. Aima, please read the review question.
Review questions. What testing would have helped the refractive surgeon identify this as a patient who might have been at increased risk for developing diplopia after refractive surgery? History, cover testing, and possible comparing the manifest encyclopedic refractions. The reduced stereopsis might also have been a clue. Number two, what findings resulting from that testing put her in the increased risk category for diplopia? History of strabismus and strabismus surgery and a history of prism glasses, considering the presence of a V pattern, she probably had measurable esotropia, at least in down gaze. She was also on the cusp of presbyopia. Number three, a 40-year-old man is referred to you by his optometrist for strabismus surgery. He has been seeing double for more than a year. His current prescription is minus 3.5 sapphire in the right eye and minus 3.5 sapphire in the left eye. These glasses are a year old. Visual acuity is 20 by 15 in each eye with correction. He has an esotropia of 15 prism diopters with diplopia. What important test needs to be performed before scheduling surgery? The patient needs a refraction. Even at age 40, he might be over minused, which could be contributing to increased accommodation and esotropia. All neostrabismus patients need a manifest refraction, and in some adults, a cycloplegic refraction may also be useful to identify latent hyperopia or axis minus power in the lenses.
Okay, very nice questions. Thank you, Dr. Aima, so much. Dr. Muhammad, do you want to add comments before we go to the question part?
No.
Okay. Dr. Sarah, Dr. Isra, Dr. Safa, anyone want to add any question, please? Is the case clear? I hope that it's a little bit difficult, maybe more than the other cases. Okay. So I will end the lecture. Thank you, everyone. Thank you so much, Dr. Muhammad, Dr. Aima, for reading. Inshallah, we will continue the next week. I will stop recording now. Thank you.